Welcome back to the deep dive. Today, we are doing something that feels a little visceral for anyone who has ever stared down the barrel of a major board exam, whether that's, the NCLEX, the USMLE, or a critical care certification.
It's a familiar feeling.
It is. And we aren't looking at a polished, peer-reviewed study today. We are looking at the trenches.
The trench is absolutely the right word. What we have here is a document simply titled Chapter 31 ShockStudent.pdf.
And let's be honest, visually, it is a disaster. I mean, it's a scrawled, frantic, handwritten note sheet. It looks like it was written by a student running on, 3 hours of sleep and maybe 4 espressos.
But, as we've discussed before, sometimes the messy notes are where the real gold is hidden.
They really are.
Absolutely. When you are in that lecture hall and the professor is talking at 2 times speed, you don't write down the fluff. You just don't have time.
No.
You write down the survival guide. You're writing down what is going to be on the test. And, more importantly, what is going to keep your patient alive one day.
And that is our mission today. We are going to take these chaotic scribbles, typos, and all reverse engineer a masterclass on shock.
I love that. Reverse engineer.
We're going to cover the physiology, the stages of decline, the specific types of shock they highlight, and the pharmacology required to fix it. And we aren't just going to define terms. We're going to really dig into the why.
Because if you understand the why, you don't have to memorize the what. That's the whole key. Shock is the ultimate test of physiological understanding. It's not just a disease. It's, in a sense, the final common pathway of death.
It's a heavy thought. Okay, so let's start where the notes start. Right there in the center of the page, there's this cluster of frantic scribbles. Vasoconstrict, with an arrow pointing up next to BP and then another arrow up next to HR.
Yep.
It looks simple, but this is it. This is the body's first line of defense.
This is the compensatory mechanism.
Yeah.
To really get this, we have to understand what shock actually is. A lot of people think it's just low blood pressure, but you can have low blood pressure and be perfectly fine. Shock is inadequate tissue perfusion. That's the definition you need for the test. Your cells are starving for oxygen.
The cells are starving, so the body senses this starvation. The notes say vasoconstriction. This isn't just a random panic response, is it? There's a system here.
No, it's an incredibly specific and beautiful reflex. It all starts with the baroreceptors. These are tiny pressure sensors located in your carotid sinus, right here in your neck, and in the aortic arch.
Okay.
When perfusion drops, the pressure inside those vessels drops, and these sensors are unloaded. They stretch less, and that decrease in stretch causes them to stop firing signals to the brainstem.
So silence is the alarm bell.
Silence is the alarm. That silence sends a signal straight to the medulla in the brainstem, and the message is clear. We're losing pressure. Do something now.
And the medulla responds by what? Just unleashing the sympathetic nervous system?
Exactly. It's like flipping a switch. It floods the entire system with catecholamines, primarily norepinephrine and epinephrine.
Adrenaline.
Adrenaline, right. And these chemicals bind to specific receptors. The norepinephrine hits the alpha-1 receptors on the smooth muscle of your blood vessels, and that causes them to clamp down hard. That is vasoconstriction.
That's the note.
That's what the student wrote down. The body is trying to shrink the container to maintain the pressure of the fluid inside. It's basic physics.
Right, like squeezing a garden hose to make the water spray farther.
A perfect analogy.
Yeah.
And that also explains the arrow up HR node as well. That's the other side of the coin, the beta-1 activation, right?
Okay, so alpha-1 for the vessels, beta-1 for the heart.
Precisely. Norepinephrine and epinephrine hit the beta-1 receptors in the heart, and that tells the heart to do 2 things. Beat faster, which is positive chronotropy,
Chronotropy. Yep.
and beat harder, which is positive inotropy. A faster, stronger pump trying to push blood through those newly squeezed pipes.
This brings up a really critical test point, and it's not explicitly in the notes, but it's implied. Pulse pressure.
Oh, yes. This is a huge one.
If you have vasoconstriction driving up the diastolic pressure, the bottom number, and a struggling heart so that the systolic isn't going up as much, what happens to that gap between the two numbers?
It narrows. It gets smaller. And that is a hallmark, sometimes one of the very first subtle signs of shock, a narrowing pulse pressure.
Can you give an example?
Sure. A normal BP might be 120 over 80. The pulse pressure is 40. But in early shock, you might see a BP of 110 over 90. The systolic has only dropped a little, but the diastolic rose because the vessels are clamped. Now that gap is only 20.
And that 110 over 90 might not set off any alarms on a monitor. It looks normal-ish.
Exactly. But it's a screaming red flag. It's a huge clue that the body is compensating, that it's fighting for its life. That's the normotensive shock trap they love to put on exams.
The patient looks fine. The BP machine says 110/90, but they are clamping down for dear life on the inside.
For dear life, they're using up all their reserves just to maintain that number.
Okay, now, moving down the page of notes, there's a whole section about fluids. I see antidiuretic, hold on to fluid, and another little scribble that says produces sodium.
Right.
This takes us from the nervous system to the hormonal response, right?
Yes, this is the second pillar of compensation. The renin-angiotensin-aldosterone system, or RAAS.
Ah, RAAS. We all learned it, probably crammed it for a test, but let's apply it here in this context.
Okay, so at the same time, the baroreceptors are sensing low pressure. The kidneys are sensing low blood flow. The kidneys hate that.
They need perfusion to work.
They do. So special cells in the kidney release an enzyme called renin. Renin floats around in the blood until it finds a protein from the liver called angiotensinogen. Renin cleaves it, and through a couple of steps, you eventually get angiotensin II.
Angiotensin II is the real workhorse here.
It's the MVP of this whole system. It does two main things that are critically important in shock. First, it is one of the most potent vasoconstrictors in the human body. So it helps that sympathetic clamp we just talked about.
So it's a double whammy on the blood vessels.
A double whammy. It reinforces that squeeze. Second, and this is key, it stimulates the release of aldosterone from the adrenal cortex, which sits right on top of your kidneys.
And that's the produces sodium note, or rather retains sodium.
Right. The student's note is a bit imprecise, but they have the right idea. Aldosterone travels to the distal tubules in the kidney, and it basically yells at them, do not let any sodium leave this body.
Okay.
It forces the reabsorption of sodium back into the blood. And where sodium goes,
water follows.
Water always follows. So by holding on to salt, you're passively holding on to water, which helps increase your blood volume.
At the same time, there's another hormone involved, right? The note says antidiuretic.
Yes. The pituitary gland, deep in your brain, senses the low pressure and high sodium concentration and releases ADH antidiuretic hormone. Some people call it vasopressin.
So it's an antidiuretic. It stops you from peeing.
Exactly. It goes to the collecting ducts of the kidney and opens up these special water channels called aquaporins. This allows pure water to be reabsorbed directly back into the bloodstream.
So the body is attacking the problem from, what, two major angles?
At least.
Yeah.
The sympathetic system is squeezing the pipes, the vasoconstriction.
Right.
And the Urantzadi system is trying to fill the pipes back up by holding on to every last drop of salt and water.
And that is why, clinically, urine output is such a vital sign in a shock patient. The note antidiuretic is the key.
It's one of the first things to go. If your patient suddenly stops making urine, you have to assume it's not just a kidney problem, it's a perfusion problem. The kidneys are sacrificing themselves to save fluid for the heart and the brain.
That's a powerful concept. The kidneys taking one for the team.
They really are. They are the canary in the coal mine for systemic perfusion.
Which brings us to another note, scribbled near the top of the page. It looks like it says stages of school, which I think is a pretty funny typo.
I saw that. We've all been through the stages of school.
Right. But it's clearly meant to be stages of shock. The student even wrote all of them underneath. This implies a progression. We just described the compensatory stage.
Right.
Everything is firing. The patient is, anxious? Their skin is cool and clammy. They're tachycardic.
Yes.
But their blood pressure is maintained.
Maintained, or even slightly high at first. This is the golden hour, or maybe the golden minutes. If you catch them here, if you identify the problem and intervene, you win. The patient does well.
But if we miss it, if the insult, the bleeding, the infection, whatever it is, continues,
then we enter the progressive stage. And progressive is the right word because it's a downward slide. The compensation starts to fail.
How does it fail?
Well, the heart can't keep beating at 140 or 150 beats per minute forever. It's a muscle, and it needs oxygen. A tachycardic heart actually has less time to fill and perfuse its own coronary arteries.
So it starts to become ischemic itself?
It does. And the vessels, they can't stay clamped forever. Eventually, they either fatigue or, more importantly, the local environment around the cells becomes so toxic with waste products that it forces them to dilate.
Okay, and the notes have a phrase here that's almost poetic. It says, progressing to center state of steel.
Yeah, that's an interesting way to put it. It's referring to shunting. In the progressive stage, the body makes a choice. It decides it can't perfuse everything.
Triage.
It's triage. It stops sending blood to what it considers non-essential organs. The gut, the kidneys, the skin, they are cut off. The blood is stolen or shunted to the absolute vital organs, the heart and the brain.
And this is where we start to see the really obvious clinical signs, like the mental status changes.
Yes. When even the brain, the most protected organ, starts to see hypoperfusion, the patient's mental state deteriorates. They go from being anxious to confused, then lethargic, or even obtunded and unresponsive.
And physiologically, at the cellular level, this is where the big invisible shift happens, right? This is the killer.
This is the most important concept for any exam and for the bedside. When cells don't get oxygen, they can't perform their normal energy-making process, which is aerobic metabolism.
Right, the Krebs cycle and all that.
All that stuff we learned, it's very efficient, makes a lot of ATP, which is cellular energy. When there's no oxygen, the cells are forced to switch to a backup plan, anaerobic metabolism.
Which is not efficient.
Terribly inefficient. It makes a tiny fraction of the ATP. And worse, its primary byproduct is lactic acid.
The famous lactate.
Famous lactate. And as this lactic acid builds up in the blood, the body's pH begins to drop. The patient goes into a state of metabolic acidosis.
And that's not just a number on a lab report. That acid is actively toxic to the body.
It's incredibly toxic. Acidosis does two catastrophic things. First, it directly depresses the heart muscle. It has a negative inotropic effect, so the heart squeezes weaker.
The exact opposite of what you need.
The exact opposite. And second, it makes the blood vessels become unresponsive to those catecholamines we talked about, to the norepinephrine.
So wait, even if your body is still pumping out adrenaline, if your pH is down to, say, 7.1, the vessels just won't squeeze anymore.
They won't. The receptors on the vessel walls literally change shape in that acidic environment. They stop working. The norepinephrine is there, but it has nothing to bind to.
That is the downward spiral. The acidosis makes the heart weaker, which worsens perfusion, which creates more acid.
And around you go. It's a death spiral.
And that leads to the final, really ominous note on the page. Irreversible, if nothing else can be done needed.
The refractory stage, or the irreversible stage. At this point, the damage is no longer about blood flow. The damage is at the mitochondrial level, inside the cells.
The powerhouses at the cell.
They're broken. The sodium-potassium pumps that maintain the integrity of the cell membrane fail because there's no ATP to run them. Sodium rushes into the cells, water follows.
And the cells swell up and burst.
They swell and light, yes. They burst open and release their contents, including powerful lysosomal enzymes that basically digest all the surrounding tissue.
So it's autodigestion. The body is eating itself from the inside out.
It is. And that's why it's called irreversible. Even if you could magically restore blood pressure and oxygen delivery at this point, the cellular machinery is broken beyond repair. The factory has been demolished.
And this is what leads to multi-organ dysfunction syndrome, or MOD.
Yes. The lungs fail, you get ARDS. The kidneys fail, you need dialysis. The liver fails, you get coagulopathy. One system after another just shuts down. And the goal of every single clinician is to never, ever let the patient get to that irreversible line on the student's notes.
So we have the timeline. Compensation, where the body fights back. Progressive, where the body starts to fail and acid builds up. And irreversible, which is widespread cell death.
That's the framework.
Okay, now let's use that framework to look at the specific types of shock that are mentioned in these notes. The student specifically highlights cardiogenic and anaphylactic.
Which is smart because they're highlighting the tricky ones, the ones that have specific, unique treatments that you have to know for an exam.
Let's start with cardiogenic. The note just says cardiogenic cause, and there's a mention of pump failure.
Cardiogenic shock is the quintessential cold and wet shock. That's a classic way to describe it.
Okay, break that down for us. Cold and wet.
Cold because, just like in other shock states, their sympathetic nervous system is firing. They are clamped down, they're vasoconstricted, so their skin is cool and clammy.
Okay, makes sense. What about wet?
Wet because the problem is the pump. The heart itself has failed, usually due to a massive heart attack, an MI. So it can't pump blood forward effectively. And if blood can't go forward,
It backs up.
it backs up.
Yeah.
And where does it back up? From the left ventricle, straight into the lungs. So they are wet with pulmonary edema.
So you'd hear crackles in their lungs.
You'd hear crackles on exam. That's the classic finding.
Now let's apply our big physiology lesson. The body senses low blood pressure and it vasoconstricts to compensate. Why is that a really, really bad thing here?
It's disastrous. This brings in the concept of afterload. Afterload is simply the resistance the heart has to pump against to get blood out.
So is how hard it is to open the door to the aorta.
Perfect. If you have a weak, dying heart muscle from a heart attack, and the body clamps down the aorta by vasoconstricting, you are dramatically increasing the afterload. You are asking that weak, tired muscle to lift a much, much heavier weight.
And it can't do it. It pushes the heart into failure even faster.
Exactly. The very mechanism that's meant to save you compensation is what actively kills the patient faster in cardiogenic shock. This is a critical point.
So treating cardiogenic shock is a real tightrope walk. You can't just follow the standard shock algorithm of dumping fluids in, right? The note says, check, song, make sure to fluids, but how does that apply here?
You have to be incredibly, incredibly cautious with fluids. Think about it. If you keep filling the tank of a broken pump, what happens?
It just overflows.
It just overflows. And that overflow goes straight into the lungs, worsening the pulmonary edema, making the patient more hypoxic.
So for test purposes, if a question describes a patient with a recent MI who has hypotension and crackles in their lungs, giving a big fluid bolus is the wrong answer.
It is the absolute wrong answer. You'll hurt them. For cardiogenic shock, you need to think about drugs that help the heart squeeze better. Inotropes. The classic one being dobutamine.
And what does dobutamine do?
Dobutamine works on beta-1 receptors to increase contractility. It makes the heart squeeze harder. But it has very little effect on alpha receptors, so it doesn't dramatically increase the afterload. It helps the pump without making its job harder.
So it's a smarter drug for this specific situation.
It's the right tool for the job.
Okay, let's pivot now to the other specific type of shock mentioned in the notes. Anaphylactic. It's a whole cluster of notes here. Immunosuppressant, steroid, and the very clear use of EpiPen.
Right. Anaphylactic shock is a type of distributive shock.
And distributive means the pipes are the problem, not the pump or the fluid.
Exactly. In this case, the tank is full, your blood volume is totally normal, the pump is strong, your heart is fine. But the pipes, the blood vessels, have suddenly dilated to, say, 3 times their normal size all at once.
And this is because of a massive histamine release.
Yes. An allergen, a bee's sting, a peanut, a medication, triggers the mast cells and basophils to degranulate, which means they just dump a massive amount of histamine and other inflammatory mediators into the bloodstream.
And histamine is a powerful vasodilator.
A very powerful vasodilator. It also makes the capillaries incredibly permeable or leaky. So not only does the container get way too big, but the fluid starts leaking out of the vessels and into the surrounding tissue.
Which is why you get hives and swelling, the angioedema.
That's the angioedema.
Yeah.
So your blood pressure just bottoms out because the container got too big and you're losing fluid from the circulation. It's a catastrophic drop.
Unlike cardiogenic shock, which is cold, anaphylactic shock is initially a warm shock, right?
It is, because of that widespread vasodilation.
Yeah.
The skin can feel flushed or hot, which is very different from the cold, clammy skin of a patient who is clamped down.
The note says very clearly, use of EpiPen. Why is epinephrine the magic bullet here?
Because it is the perfect physiological antidote. It does exactly the opposite of what the histamine is doing. Well, epinephrine is a potent agonist for both alpha and beta receptors. The alpha-1 effect causes massive vasoconstriction. It clamps those dilated vessels shut, which brings the blood pressure right back up.
So it shrinks the container back to its normal size.
Instantly. And the beta-2 effect causes bronchodilation. It relaxes the smooth muscle in the airways, which have clamped down because of the histamine. So it opens their airways so they can breathe again.
So it fixes the blood pressure and it fixes the breathing.
It's the perfect antidote. It's life-saving. But, and this is another key test point, you have to give it immediately. And you have to give it IM, intramuscularly, in the thigh.
Why not intravenously?
In the field, getting IV access on a patient whose vessels are dilated and whose pressure is non-existent is nearly impossible. IM into the big muscle of the thigh provides rapid, reliable absorption.
What about the steroid note? And there's another one about immunosuppressant.
So steroids, like methylprednisolone, and also antihistamines, like diphenhydramine or Benadryl, are absolutely part of the treatment. But they are secondary because they take hours to start working. They are crucial for preventing what's called the biphasic reaction, a second wave of inflammation that can happen 4 to 8 hours later. But they do not fix the immediate, life-threatening hypotension and bronchospasm.
So for a test question that asks what the first most important intervention for anaphylaxis is,
It is always epinephrine. Maintain the airway, give epinephrine, everything else comes after.
Now, the notes don't explicitly detail septic shock, but it's the elephant in the room when you talk about shock. It's the most common type we see in the ICU.
It absolutely is.
It's also a distributive shock, like anaphylaxis. Do they look similar?
Mechanistically, yes, in that the pipes are the primary problem. In sepsis, It's not histamine, but rather bacterial toxins and the body's own inflammatory response cytokines that cause the massive vasodilation and leaky capillaries.
So septic patients are also warm initially?
Yes, this is classic warm shock or hyperdynamic shock. The patient often has a high fever, their pulses are bounding, their skin is flushed. But as it progresses and they can no longer compensate, they'll clamp down and become cold, just like any other shock state.
And the treatment for sepsis ties directly into the general fluids and vasoconstrictor notes we see on this page.
It does. It's the quintessential example of needing to fill the massively dilated tank with fluids and then squeezing that tank with vasopressors to restore pressure.
Specifically, for the exam, students should know about the sepsis bundles, right?
Yes, the Surviving Sepsis Campaign bundles are key. The big one is the fluid resuscitation. 30 milliliters per kilogram of crystalloid fluid given within the first 3 hours of recognition.
That is a huge amount of fluid. For an average person, that could be 3 or 4 liters.
A ton of fluid, but that's what it takes to fill that dilated, leaky vascular space.
That leads us perfectly into the toolkit section of the notes. We've talked about the problem, now we need to talk about the fix. The note says, very simply, check for make sure to fluids.
It's step one for a reason. This is the cornerstone of treatment for hypervolemic, septic, and anaphylactic shock. You absolutely must restore preload, which is the volume of blood in the ventricles in the end of diastole. You have to fill the tank.
Let's talk about the fluid choice. The notes just say fluids.
Yeah.
But on a test, you can't just grab any bag off the shelf. What are we using?
You want to use isotonic crystalloids. That's your buzzword.
Yeah.
The two main ones are normal saline, that's 0.9% sodium chloride in lactated ringers, or LR.
Okay, is there a preference between the two? Does it matter?
You know, it's actually a massive debate in the critical care world right now. For a long time, normal saline was the go-to. But we've learned that if you give massive volumes of it, the high chloride content can actually cause a hyperchloremic metabolic acidosis.
And we just spent 10 minutes talking about how acidosis is the enemy of shock treatment.
Exactly. You're potentially making the problem worse with your treatment. So many clinicians and institutions are now shifting to prefer lactated ringers.
YLO.
It's a more balanced solution. The lactate in it is actually converted by the liver into bicarbonate, which helps buffer the acidosis of shock. Its composition is much closer to human plasma. For the exam, usually isotonic crystalloids is the right answer, but knowing the LR versus saline nuance is definitely high-level thinking.
Good to know. Okay, after fluids, the note says, give them some drugs to vasoconstrict.
The vasopressors, the big guns.
We used the analogy before. Fill the tank, then squeeze the tank. Why is that order so important?
Imagine you have an empty juice box. If you just squeeze the empty box, what happens?
Nothing. You just get a flat box.
Right. No juice comes out the straw. You have to fill the box with juice first. That's your preload, your fluids. Then when you squeeze it, that's the vasoconstrictors. You can actually generate pressure and get juice out the straw. That's your cardiac output and blood pressure.
So fluids first. If the MAP, the mean arterial pressure, is still low after you've given fluids, then you start the pressors. Which one do we start with?
The first-line vasopressor for almost all shock states, especially septic and cardiogenic, is norepinephrine. The brand name is Livofed.
I've heard that old rhyme, Levofed, leave 'em dead. Is there any truth to that?
That is a very old, very outdated, and frankly dangerous rhyme. The idea was that Levofed clamped down peripheral vessels so hard that it caused limbs and kidneys to die.
Okay.
What we now know, unequivocally, is that hypotension kills kidneys and limbs. Levofed actually saves them by restoring the perfusion pressure they need to survive. It's a life-saving drug.
So it got a bad rap. What about dopamine? I remember that being a big one in older textbooks.
Dopamine has really fallen out of favor. We have better, more specific drugs now. The main problem with dopamine is that it has a much higher risk of causing tachyarrhythmias, dangerous fast heart rhythms.
I see.
It's really only used in a very niche situation now, perhaps if the patient has profound bradycardia, a very slow heart rate, and you need to speed them up while also getting some squeeze. But for most shock, you go straight to Levofed.
And what about vasopressin? We mentioned that earlier as ADH.
Yes. Vasopressin is usually the second-line drug that we add to Levofed if the patient is still hypotensive. It's a great adjunct because it works on completely different receptors.
How did that help?
Levofed works on alpha receptors. As we said, in a severely acidic environment, those receptors can stop working. Vasopressin works on V1 receptors, which are not affected by pH, so it can still cause vasoconstriction even when Levofed is losing its effectiveness.
That is a crucial nugget for a test. If the patient is acidotic and not responding to Levophed, adding vasopressin is the next logical step.
It is. You can think of it as hormone replacement. In profound shock, the pituitary's natural stores of vasopressin get depleted, so you're just giving it back to them.
Let's address another medication note here. It's a bit garbled. Insulin because of hypoglycemia. I'm pretty sure this means hyperglycemia.
Yes, that's almost certainly what they meant. Stress, hyperglycemia.
Why does this happen? Is it just because of the cortisol release we talked about?
It's a combination of things. It's the body's attempt to mobilize fuel for a fight-or-flight situation. The massive surge of cortisol and epinephrine stimulates the liver to break down its glycogen stores and dump sugar into the blood. That's glycogenolysis.
So the body is trying to make sure the brain and muscles have enough fuel to fight the tiger, so to speak.
Exactly. The problem is, in a critically ill patient lying in an ICU bed, that high blood sugar is actually harmful.
How is it harmful?
Well, for one, it impairs the function of neutrophils, which are key immune cells, so it increases the risk of infection. It's also an osmotic diuretic, meaning high sugar in the blood pulls water with it into the urine, causing you to pee out the precious fluid you're desperately trying to give back to the patient.
So we treat it even if the patient isn't diabetic.
Yes. We treat it with an insulin infusion to keep their blood glucose in a tight range, usually something like 140 to 180 milligrams per deciliter.
So another key test point. You see a trauma patient with a blood sugar of 250. Your first thought shouldn't be undiagnosed diabetic. It should be severe physiologic stress.
Correct. And you treat the number, regardless of their past medical history.
Okay, let's move into the monitor section of the notes. There's a fragmented line, signs that a limb that tell the med staff, and then just the words, on monitor.
Right, so we need to talk about what numbers we're actually looking at on that monitor. What are we trying to achieve? We mentioned pulse pressure. What about MAP?
Mean arterial pressure.
Yes. This isn't just the average of the systolic and diastolic. It's a calculated number that represents the average pressure in the arteries during one full cardiac cycle. And for shock, the magic number to know is 65.
MAP greater than 65 millimilli-Hg. Why that specific number?
Through years of research, we found that 65 is the minimum pressure required to overcome the internal resistance of the organs and drive blood into the microvasculature, especially the kidneys and the brain. It's the minimum perfusion pressure for your vital organs.
So below a MAP of 65, your GFR, your kidney filtration rate, essentially drops to 0.
It stops. Your kidneys shut down. So in the shock room, all eyes are glued to that MAP. We are titrating our fluids and our Levophed with the singular goal of maintaining a MAP greater than 65.
What about central venous pressure, or CVP? The notes say make sure to fluids. How do we know when we've given enough? When is the tank full?
That's the million-dollar question. CVP is a measure of the pressure in the right atrium, which is a surrogate for preload. Normal is roughly 2 to 8 millimeters of mercury.
So if the CVP is low, like 1 or 0, the tank is empty.
The tank is empty, give more fluids. If the CVP is high, say 15 or 20, the tank is likely full, or even overflowing, which could mean the heart is failing.
CVP has become pretty controversial, hasn't it?
It has, because it's just a static number. It doesn't tell you what will happen if you give more fluid. That's why we're moving more towards dynamic measures of fluid responsiveness. The best example is the passive leg raise.
Walk us through that. How does that work at the bedside?
It's brilliantly simple. You have the patient in a semi-recumbent position. You record their blood pressure. Then you lay them flat and lift their legs up to 45 degrees.
Right.
Gravity pulls all the venous blood from their legs, about 300 to 500 milliliters, and dumps it into their heart. It's like giving them a rapid, temporary fluid bolus of their own blood.
An autobolus.
An autobolus. You then watch the blood pressure monitor. If their blood pressure and cardiac output shoot up in response, it means they are fluid responsive. Their heart is able to handle more volume, so you should give them more IV fluids.
And if nothing happens?
If their blood pressure doesn't change, it tells you their heart is already at its max preload. Giving more fluid won't help and might even hurt. That's your signal to stop the fluids and focus on the vasopressors.
That is a brilliant, non-invasive test. It's just using physics.
It's just physics in action. It's one of the smartest things we do in the ICU.
One thing we haven't touched on deeply yet is oxygen. The note just says probably going to be on O2. Seems obvious, but what's the physiology?
It all comes down to the balance of oxygen delivery, which we call DO2, versus oxygen consumption VO2.
Okay.
In shock, consumption VO2 is incredibly high because of the metabolic stress, but delivery, DO2, is critically low because of poor blood flow. There's a massive mismatch.
So the goal is to increase delivery. We can do that by improving blood flow with fluids and pressors and by
Yeah.
just putting them on 100% oxygen.
We maximize the oxygen content of the blood they're circulating. So
Mhm.
yes, we'll put them on a high concentration of oxygen via a non-rebreather mask or even intubate them. But, and this is crucial, oxygen doesn't help if the blood isn't moving.
So a pulse ox reading of 100% can be falsely reassuring.
Very.
Okay.
You can have a saturation of 100%, but if your cardiac output is terrible, the cells are still suffocating because the oxygen-rich blood isn't getting to them.
Yeah.
That's why we focus so much on flow on cardiac output and blood pressure.
Right. I want to circle back to the irreversible concept for a second and link it to a specific lab value we mentioned, lactate.
Serum lactate, yes.
If I'm a student looking at a chart and I see a lactate of 4.0 millimole Lmount, what should my brain be thinking?
Normal is usually under 2. A level of 4.0 tells you, unequivocally, that there is significant anaerobic metabolism happening somewhere in the body. It's a direct measure of tissue hypoxia. The cells are suffocating.
So it's a number that quantifies the severity of the shock.
It does. And even more importantly, we track it over time. We look at lactate clearance. If you start your resuscitation and you recheck the lactate in a few hours and it's gone from 4 down to 2, you are winning. Your interventions are working.
And if it keeps going up?
If you've given fluids, you've started pressors, and the lactate is now 8, you are losing. The patient is marching steadily toward that irreversible stage.
So lactate is basically your scoreboard for resuscitation.
It is the truth teller. Blood pressure can lie because of compensation. Heart rate can be confounded by medications. Lactate tells you the truth about what's happening at the cellular level. It tells you if your cells are happy or not.
Let's spend a moment on the last note on the page, which almost seems out of place. It says, teach PTS and family when they go home first.
Yeah, it seems disconnected from all the ICU drama, but it's actually incredibly important. Shock doesn't just happen in a vacuum. It has causes. And if you don't fix the root cause and educate the patient, they will bounce right back into the hospital.
So for anaphylaxis, this is the classic EpiPen teaching.
It is. You have to teach them how to use it. Blue to the sky, orange to the thigh. You teach them to hold it in place for 3 to 10 seconds. You teach them to massage the site after. And this is the most important part. You teach them to call 911 or go to the ER immediately after using it.
Because of that biphasic reaction, the rebound.
Exactly. The half-life of injected epinephrine is just a few minutes. The allergen in their system can last for hours. The EpiPen buys them time to get to definitive medical care.
Okay, what about for cardiogenic shock? What's the go-home teaching there?
That's comprehensive heart failure education. They need to know about weighing themselves every single day to watch for fluid retention. They need to understand their fluid and salt restrictions, and they need to be perfectly compliant with their medications. The ACE inhibitors, the beta blockers.
And for septic shock.
That's about infection prevention. For some patients, it's about proper wound care. For others, it's about recognizing the early signs of an infection, like a UTI or pneumonia, and seeking care before it gets severe. It's teaching them to say, if you have a fever and you feel more confused than usual, you need to come in. Early recognition is what prevents the shock state from ever developing.
We've covered a ton of ground here. I want to try and synthesize this into a kind of battle plan for the listener. Imagine you're a new nurse or a medical student and you walk into a room. Your patient is pale, they're sweaty, their heart rate is 130, and their blood pressure is 85/50.
Okay, a classic, undifferentiated shock presentation.
Step 1. What do you do in the first 30 seconds?
ABC, airway, breathing, circulation, always. Is their airway open? Are they breathing effectively? If not, fix that first. Slap an oxygen mask on them.
Okay, airway is good. Step 2. Access and diagnostics.
You need 2 large bore IVs, that means 18 gauge or bigger. You need big pipes to get fluid in fast. As you're putting them in, draw blood for everything. Lactate, CBC, electrolytes, coagulation studies, and blood cultures before you give antibiotics. And get them hooked up to a continuous monitor BP cuff, cycling every few minutes, continuous heart rate, and a pulse oximeter.
Got it. IVs, labs, monitor. Step 3, fill the tank.
You start that fluid bolus immediately. The standard is 30 millimole per kilogram of an isotonic crystalloid like lactated ringers or normal saline. You hang the bag and run it wide open. Squeeze the bag if you have to.
Unless. There's always an unless.
Unless you have a strong suspicion of cardiogenic shock. If the patient is telling you they have chest pain, if you hear crackles in their lungs, you need to be very cautious with those fluids. Or, the other big one, if it's hemorrhagic shock, if they're actively bleeding, then they need blood, not saline. Saline doesn't carry oxygen.
Okay. Step 4, reassess and squeeze.
After that first fluid bolus is in, you reassess. Did the blood pressure come up? Is their heart rate coming down? Did they start making urine? If they are still hypotensive, that's when you start the norepinephrine, the Levophed. You start it at a low dose and titrate it up until their MAP is greater than 65.
And the final step, step 5, find the cause.
Yes. While you're doing all of this, you have to be a detective. Is this sepsis? Then you need to get broad-spectrum antibiotics on board within the first hour. Is it anaphylaxis? Give the IM nephrim. Is it a massive pulmonary embolism? They might need thrombolytics. You have to turn off the faucet, not just keep mopping up the floor.
I love that analogy. Turning off the faucet versus mopping the floor. The fluids and the pressors are just mopping.
They're just mopping. They are buying you time for the definitive treatment, the antibiotics, the surgery, the antidote to work.
Before we wrap up, I just want to address that stages of school joke one last time. We laughed, but thinking about it, is there an actual physiological parallel between shock and the anxiety of taking a high-stakes test?
Oh, absolutely. It's a perfect parallel. When you sit down for a big exam, you are in a mild compensatory shock state. Your sympathetic nervous system is firing.
So your catecholamines are high.
Your heart rate is up. Your pupils dilate, theoretically, to help you see the questions better. Blood is shunted away from your gut and towards your brain. It's a classic stress response.
But what happens if you panic? If the anxiety gets overwhelming?
You start to hyperventilate. You breathe too fast and too deep. You blow off all your CO2, causing a respiratory alkalosis. And here's the kicker. Low CO2 levels in the blood cause profound cerebral vasoconstriction.
So you literally get less blood flow to your brain.
You get less blood and oxygen to your brain at the exact moment you need it most. You can't think clearly. Your memory recall fails.
So the age-old advice to just take a deep breath is actually physiologically sound medical advice.
It is. Taking slow, deliberate breaths helps you retain a bit of CO2, which helps dilate those cerebral vessels, improves blood flow, and helps you think. Don't let your test anxiety send you into the progressive stage of cognitive failure.
I love that. The physiology really does apply to everything.
It really, really does.
So we've decoded the messy notes. We've turned hyperglycemia into a discussion on stress, hyperglycemia, and cortisol. We've turned produces sodium into a deep dive on the renin-angiotensin-aldosterone system.
And hopefully we've helped move the listener from just memorizing BP down, HR up, to actually understanding that intricate, beautiful dance of baroreceptors, chemoreceptors, hormones, and cellular metabolism.
That is always the goal, to see the matrix behind the symptoms.
Because when you are in that room and the monitor is alarming and things are going badly, you don't have time to look things up. You fall back on your training. You fall back on your understanding of the why.
Well, thank you for guiding us through the trenches and helping us find the gold in these notes today.
It was my pleasure. Always is.
To our listeners, keep your MAPs above 65, keep your lactate low, and remember, always fill the tank before you squeeze it. We'll see you on the next deep dive.